Thank you for the opportunity to discuss top 5 innovations in TAVR in 2020 in my mind. These are my disclosures. In my mind, these are the top 5 innovations in 2020, which we hopefully will also see more of in 2021. First thing is devices for aortic regurgitation. We have seen a sizable experience with dedicated TAVR delivery systems and devices such as Yanaval and JVAL. The main challenge has been sizing, as we know that a lot of aortic regurg patients have very large annuli. The second, of course, is oversizing is needed, and hence the risk of pacemaker has been pretty high. Depending upon TTE in challenging anatomies, such as in horizontal aortas, I think is critical, and hence some patients need general anesthesia. And so lastly, but not the least, is a double profile. As you can see, there's a stent on a stent, and hence the profile. However, majority of these obstacles will be overcome with experience, and I think there's been a very good experience with both the devices, especially with Yanaval, which is predominantly transfemoral. Tailored expansion and intermediate sizes has been predominantly seen from 2019 and 2020. Now, what I mean by that is that operators tend to underexpand and overexpand a particular device. Now, we have seen some companies also coming out with intermediate sizes. This is very critical, as we know that majority of the TAVR devices are function best when it's fully expanded, and hence under and over expansion is of course deleterious to the device. It has leaflet effects on leaflet coaptation, and then hence durability as well as predisposition to leaflet thrombosis. We can appreciate this in frame A and C as against frame B, where there's a good coaptation. That all this is going to lead to pinwheeling, higher gradients, and more leaflet stress. Some of the devices have come with intermediate sizes, and what I mean by that is there has been a jump of 2 millimeters instead of 3. However, certain balloon expandable devices have come with intermediate sizes now. So we have something like 21.5, 24.5, 27.5, and even larger sizes, and hence you can use precise sizing and avoid under or over expansion, and we will see in future same kind of design in many other ones. The third is puzzle of durability. This is just a case of sapien in MAC and being again dilated with few cc's more, and one can see what happens with inflation once the operator is testing the valve. And you can clearly see on testing that there is imprint of sapien cage on the leaflets, and this is definitely going to affect durability of this whether we like it or not. Further, we do not know the effects of crimping as we aim for smaller and smaller frame sizes, but what it poses industry is a challenge, and research in better leaflet technology. We also need not just new leaflets and better understanding, but we also need clear definition, because there has been a lot of confusion about durability and ppm, and I think the definition of durability clearly needs to be either histopathological or clinical. Getting echoes done also on serial may increase our understanding, but the confusion about leaflet thrombosis versus structural degeneration will always remain. This is going to impact our understanding of using age cutoffs for bioprosthetic valves, and as we call it, as lifetime management of the patients. We hence will modify our definitions of old patient and young patients, which according to me are again matched with durability with life expectancy. The two new leaflet materials we have seen in clinical practice now is one is Resilia by Edwards Life Sciences and Adapt by Admit. Resilia tissue is predominantly implanted at present with Inspiris and Connect aortic conduit. But we have also seen it being used in Centera as well as Fortis in the past. However, both these transcatheter valves have been withdrawn. We are going to see more long-term and longitudinal data of this particular tissue, but in animals definitely it showed promise. Adapt tissue developed by Admidas has been predominantly used in pediatric surgery and on the right side. There is an effort at present to develop transcatheter as well as surgical implants which have now been done. The beauty of this tissue is that it is decellularized, cross-fixed and detoxified tissue. Hence, in summary, leads to no inflammation as there are no DNA sites for calcium binding. The second biggest advantage is with the processing, one can not only use a single piece pericardium, but this pericardium can be 3D molded, and this molding obviously increases the chances of better coaptation as well as distribution of stress. And again, we are going to see whether the promise which has been shown in early studies holds true long term. Commissural alignment is a subject very dear to me. As a surgeon, I always felt that we align commissures of all the surgical valves, and that might impact the durability and blood flow of the tissue when we use TAVR device. And we showed very clearly that TAVR devices land anyhow, and they can be completely misaligned or partially misaligned when they are implanted. This not only is important for frame expansion and sealing, but now we know that it is important for coronary access as well, especially for taller devices. And of course, it can impact TAVR in TAVR as well. So we need dedicated systems which can allow us to implant the device in near perfect commissural alignment. And this is what we are going to see late 2020 and 2021. Lastly, but not the least, we have learned a lot on reintervention for failed TAVRs. Is TAVR in TAVR a good option? Which patient it is better? Or explanting TAVR is better? Or is it too much of a surgery now in a patient who has gone TAVR route? THV and THV is a good strategy, but we have only few cases. There are issues on hemodynamics. Again, I am focusing on midterm outcome and not early outcome, which has been reported. There's obviously a higher risk of thrombosis and need for anticoagulation because now you've got multiple stents which are in the small area of sinus. And if we are going to anticoagulate these patients, then might as well put a mechanical valve and do this operation only once. But what about TAVR explant? If patients are low and intermediate risk, I think it's a much better and elegant option. The techniques are slightly different in explant. Or taller devices against shorter. The taller devices engage with the aorta but are easier to explant from the annulus, while shorter devices tend to engage more in the annulus and need a specific technique to prevent damage to mitral leaflet and conduction. And again, we'll be presenting the registry results at in TCT as well as London Valve. With learning curve, I'm quite sure that this operation is going to be low intensity rather than high as we thought. So just to summarize these 5 innovations we have seen, not just in terms of different devices and delivery systems, but the need for it, but also we are understanding now how TAVR falls in the lifetime management of the patient. Thank you very much.